Thank you very much indeed, and welcome back. I'm sorry it was a rushed lunch. I'm going to press on. This is quite a tight schedule that we've got, but like the Secretary of State, our next speaker really needs no introduction. He's now served under 4 governments, covering Labour, Coalition, and now Conservative, and he's steered NHS England since 2014. He was described as the second most influential person in the NHS even before he took the job. And since then, he has become the most influential person, according to HSJ anyway, for the NHS. Please welcome Simon Stevens.
Thanks, Neil. So, as Neil says, you've heard a lot by this stage of the proceedings, so I'm going to cut straight to the chase. I think there are 3 questions that are on people's minds that I just want to spend a moment talking to you about, and then we'll have a chance to discuss further. First up, where do we think we are? What's our current situation, kind of given where we've got to at the end of 16-17, all the pressures we know about and have been debating? Second, what's the plan, the practical plan in the light of that to try and square the circle between those pressures and what we know needs to get done over the course of the next year? And thirdly, it's not just about firefighting. It's also about future-proofing our services and the NHS for what we can see are some big challenges headed our way. So where do we stand on those 3 questions? Well, starting with the here and now then, of course, I'm talking with people who were involved in the Grenfell Tower fire last night. So much has already been said, not only here in Liverpool, but over the last few weeks, about the bravery and the professionalism of NHS staff in confronting the 3 major terrorist attacks that we've had in recent weeks. We've talked about the sacrifice of Kirsty Bowden, and the story that I think is exemplifying what we see for so many people across the NHS, that of Dr. Sengotian Chandrasekaran, who, working in Manchester, picking up his daughter and a friend at the Ariana Grande concert, standing in the foyer, found himself less than 20 feet away from the terrorist bomb. So he quickly established that his daughter and her friends were okay, took them home, and then went straight to Stepping Hill Hospital, where he works in Stockport. Worked all night in intensive care and theatres, and only at 6 o'clock that morning told his colleagues where he'd been before coming into work, and then went straight back into work next morning. These are the heroes of our country, these are the heroes of the NHS, and we know that it's not only these terrible circumstances that bring out the best in our frontline staff, it's actually these kinds of acts which happen day in, day out. On that night, on those nights, the NHS looked after people of many different nationalities, and the NHS staff who are providing that care come from many countries around the world. I think at this time of national debate, there's no contradiction between recognizing the value and importance of continuing to grow more staff from this country, while also taking care and looking out for our international staff. And I therefore very much welcome the comments that Jeremy made this morning about the stance that will be taken in the Brexit negotiations. I think there was another lesson that came out of the fabulous response to these attacks, and that was that actually part of the reason services work so seamlessly was because we have now got major trauma networks across England. And it was the idea that ambulance services and hospitals network together rather than each individual part of the NHS doing its own thing. That's the way to respond to these major occasions. And it set me thinking that that's probably true for a wider range of the pressures and problems that we're facing. We know, for example, that we've made major strides in stroke services over the course of the last 10 years, and over 80% of patients in this country are now being looked after by stroke units that are rated good or excellent on the stroke audit. But we've still got around a third of stroke units in parts of Yorkshire, the north of England, the northwest coast, the southwest, where we're not meeting those standards. And as the Stroke Association, the patient's representatives say, we need to get on with it. So it is not an act of financially driven clinical concentration when we get serious about making these changes for our patients. It is an act to improve the quality of care, and it's an act that we need to get on with in many parts still of this country. But all that said, it's no wonder that the public are still extraordinarily grateful and positive about the National Health Service. We've obviously just been through a complicated election, but I think as we look back on not just the last year, but the last several years, it's well worth remembering that public satisfaction with the work that you do, with the work of your teams, is the highest it has been in all bar 3 of the last 30 years. And by the way, at a time of some division in our country, it's worth remembering that that does not matter whether you vote blue, red, yellow, green, or any of the other colours that now constitute our parliament. I'm not quite sure what they all are. The fact is that the NHS is a unifying force, and that's the support we have. But there are 5 big paradoxes about the circumstances that face us. We are getting healthier. It has been amazingly the case that life expectancy has been going up by 5 hours a day. It's kind of extraordinary when you think about it. That means the hour we spend together now, I will have given you 12 and a half minutes of life. It may seem we spent 5 hours together based on how long I drone on for, but actually you'll live 12 and a half minutes longer as a consequence. So at least hold on to that fact. But at the same time, we're going to have another 2 million people aged over 75 with us over the course of the next decade. Fabulous. Of course, looking after somebody aged over 75 costs 3 times more than looking after a 30-year-old. So are these real pressures? We've heard throughout this conference about the quality gains that are undoubtedly being made, but also about the honesty and transparency that means those are laid bare where there are problems and mistakes, and that is the culture of candor and the culture of improvement. So I think we do still have a consensus actually about the National Health Service, and indeed a consensus about how it needs to change. But the challenge for all of us is, can we both keep the show on the road and reinvent care in the way that we can all see is needed? So, what's the plan? Well, it turns out we do have a plan. We have a very concrete plan, a plan unaffected, I would argue, by any of the recent developments nationally, a plan that was published at the end of March, and a plan that, for any of you not intimately familiar with, I suggest you dust it down and have a look, because this actually is what we're going to collectively be spending our time on in all parts of the health service over the next 12 and 24 months. And to cut to the chase, there really are 5 overriding priorities that we've got to get right over the course of the next year. This is not the sum total of all the brilliant work that will be going on across the NHS, but these 5 really constitute the core things that we have got to show improvement on. On A&E, I think before we talk about what needs to change, we need to understand what's just been happening. And actually, the picture is quite an interesting one. If you look at the period January to March this year, and compare that with January to March last year, so quarter 4 compared to quarter 4, what you see is that actually the number of A&E attendances was down, but the number of emergency admissions was up. You see that in distinction to previous trends, actually the number of hospital beds went up on average throughout last year, and was up indeed in the last part, even when we had this terrible winter. But the big change, of course, was that the actual availability of those hospital beds fell as a result of these transfers, delayed transfers of care, which is why central to ensuring that we have a better performance in the winter ahead has got to be getting serious, not just about front-end demand, but also about flow through hospitals and the connections with NHS-related discharges and social care-related discharges. And that's the conversation that we're having with our colleagues in local government. But there are, frankly, a set of very practical things that Pauline Phillip and colleagues working with Jim and me are very clear need to be happening everywhere. And when those actions are applied, we see improvement. So this is just kind of a fundamental that we need to get right so that over the course of the coming year, we're able to show A&E performance has improved relative to last year, and we want to get back to a situation where during 2018, we are meeting the 95% standard. Jim talked yesterday about a number of the challenges and the progress that's being made in the trust sector, particularly the hospital sector. I just want to take this opportunity to complement that by talking about what needs to happen in primary care over the next 12 months. I think we all know that GPs look after about 300 million patient visits a year, compared with 23 million to A&E. So what happens in general practice has a profound impact on the overall experience and quality of care for people in this country. And yet, if you look at what has happened to staff numbers over the last 6 or 7 years, you can see that whereas we've made significant workforce investments in hospital consultant growth, that has not been the case in general practice. So one of the things, of course, we've got to get right is we've got to turn the corner on funding for general practice and primary care. And I'm proud of the fact that in every year since NHS England had responsibility for this, we've begun to turn the corner and increase real investment in primary care. But there are a whole series of things we've got to do on GP retention, on new trainees, on return to practice, and this should be of equal concern to leaders of community trusts and acute trusts, as much as CCGs and GP consortia in every part of the country. The practical things we've got to get right: we want to have 900 pharmacists in general practice by March. We want to have 800 mental health therapists working alongside GPs, a big program of further investment in GP premises. So this is not a sort of theoretical debate about what we want to do with primary care. There are some practical actions that we need to get right in every part of the country, and that will begin to make a difference. One of the differences it will make is that we know that the reality of ease with which people can get GP appointments, the perceptions of that, not just during the working week, but also evenings and weekends, that has been deteriorating in recent times. And so part of the target investment in staff and in funding needs to go into extending access at evenings and weekends. And half of the country, thanks to the plans that CCGs and GPs have now agreed, will be covered by next March, on track for full rollout by the following March. So the primary care piece is absolutely essential. As a leader in the BMJ put it, if general practice fails, the NHS fails. All of us have a responsibility to make sure that the agenda we've set in primary care actually now is turned into reality in each part of the country. But it's not just about urgent and emergency care. It's not just about primary care. It's also about some of the big clinical priorities, service improvement priorities that the country has set for us and we've set for ourselves. We know that 1 in 4 people have a common mental health problem. During their lives, more than 1 in 3 of us will get cancer. And so we've got a very tangible and concrete set of improvements on mental health services, targeted investment, on CAM services, mother and baby units, on expansion of the IAPT program. Again, these are what delivery looks like on mental health over the next 12 months. For cancer services, actually, we've got an incredibly positive story to tell for the people of this country. Cancer outcomes, of course, are the highest they've ever been. We're saving about an additional 2,500 lives every year relative to what would have been the quality of cancer care the year before, and we're determined to make further steps on that journey this year. But one of the things we've got to get right is the Cancer 62 waiting time standard. And if we don't get that right, then lots of consequences flow in terms of early diagnosis, and so that has to be firmly on our agenda for the year ahead. But we're also going to be making big investments in upgrading our radiotherapy treatment services, the LINAC program, and alongside that, really getting to grips with some of the challenges faced by innovative new cancer medicines. I'm pleased that with NICE, NHS England is now in a position to more assertively negotiate creative and flexible reimbursement arrangements with the drug companies. I think we've used that to good effect over the course of the last year, and as a result have reduced the overspend on the Cancer Drugs Fund by £125 million in just the last 12 months, with the result that the New Look Cancer Drugs Fund is now balancing its budget. And today I'm pleased to announce that we've also reached agreement with one of the companies, Roche, on one of the drugs, Kadcyla, which has been under review by NICE since at least 2015, originally rejected for being too expensive. We will be doing more of these kind of negotiations and agreements to get maximum value for patients and taxpayers out of the NHS's growing investment in modern medicines. All of this, of course, requires continuing financial discipline. I think Jeremy talked about it. I think Jim talked about it. Jim shared with you the good outcome on the trust financial position for 16-17. I'm pleased to say there was equally strong financial performance by CCGs and NHS England. 3 years ago, we produced a managed surplus of £250 million. Last year, we increased that to £499 million. The year just gone, we were targeting £800 million. In fact, we managed to deliver £903 million to offset those pressures that were in other parts of the system. So together, I think you've got an awful lot to be proud of. The NHS and the Department of Health in the round will have balanced its books in what obviously was a very tough year. But the bad news, as Jim said, is unfortunately we've got to do it again. And we've got a sort of clear set of actions we know we need to take. I'm not going to run through all of those, but the Productive Hospital, the Model Hospital Programme that NHSI have developed, the right care work, the local engagement that NHSI and NHS England are bringing in different parts of the country, we're going to have to, I'm afraid, do that again this year, because if we don't get the financial balance in the system, that is going to crowd out our ability to do so much else we want, and it's also going to undermine our argument that we are effective stewards of further funding for the National Health Service. All right, so far so practical, but so far so tough in terms of the change program for urgent emergency care, primary care, cancer and mental health, the changes we need on efficiency and financial discipline. But of course, this is not all, a lot of this is about the here and now. There's a much more profound change agenda that is what motivates a lot of us and a lot of us can see as required. That is the care redesign agenda. When we set out the original forward view a couple of years ago, we sort of really argued that in comparison with previous approaches to change in the NHS down the years, we needed to sort of think differently. Rather than focusing on mucking around with administrative deck chairs, we needed to focus on the actual service outcomes we wanted to improve. We wanted to do this jointly in terms of setting out these strategies with our partners across the service, including the voluntary sector. A recognition that the country is sufficiently diverse that we can't do the same thing in every place, horses for courses, and it's going to have to evolve. And that, I think, we have been doing, and I think we are beginning to see some results. Now, there's not to say that there won't always be skeptics anytime you try and come up with something new or change program. One of the non-exec directors of NHS England is a guy called John Byrne, geneticist from Newcastle. He and I were talking about this a few weeks ago, and he pointed me to this rather brilliant parliamentary report with reference to the Treasury on the question of steam engines back in 1822. And this was a report to King George IV by the parliamentary committee asked to investigate Messrs. George and Robert Stevenson, colliery engineers of Killingworth. And their report said, "The elder gentleman is unlettered, but professes a rude mechanical aptitude. His son received a modest public education in Newcastle on Tyne. They are possessed of a remarkable fancy that the steam engine, now employed to drain the collieries in their district, might be adapted for the purpose of locomotion, and it might carry passengers between London and the northern industrial districts at speeds of up to 30 miles an hour. We believe, as Parliament, that this is a result of their distempered imagination, probably occasioned by the severe climate and privation experienced in the northern districts, and frequent recourse to spirituous liquors that all too frequently results. Representatives of Her Majesty's Treasury have pointed out to us that the latest horse-drawn mail coaches between London and Manchester, as long as sustained by frequent changes of horse and travelling by turnpike on Mr. McAdam's patented surfaces, have achieved the remarkable speed of 10 miles an hour, which we regard as adequate. And we conclude that no possible gain in human welfare could result from any attempt to reach a higher velocity. Now, for all of you engaged in change in the National Health Service, it may occasionally feel as if you're on the receiving end of missives such as that. But the reality, of course, is that actually care redesign works. We're beginning to see this in the vanguards, where the most intense version of the vanguards are cutting the rate of emergency hospitalizations by 2/3. We're seeing it in terms of the redesign work at the interface between general practice and outpatient departments, where we've seen a reduction of 2/3 across England in the referral rate over the course of the last year. And in places like Ipswich, they report, as a result of the combined work of the hospital and the GPs, actually they've cut referral rates in absolute terms by 11% over the course of the last year. Andrew Morris, down in Frimley, who's unfortunately not here, their creation of practice hubs for half of their area has reduced referrals by 7%, compared with the other part of their area where they haven't yet done that, and they're up by 10%. So the fact is that this recipe works. We've just bloody well got to get on with it. And so the challenge there is, how do we set the right framework? How do NHSE and I help with that rather than get in the way of that? And how do we back improvement and leadership where we find it? Well, the good news is there are many places gagging to get on with it, and today I'm pleased to announce the first wave of the accountable care systems across the country, covering 7 million people. We're putting at their disposal £450 million of funding that would otherwise have been centrally controlled for them to drive over the course of the next several years. And in addition, today, we've signed a devolution agreement, a health devolution agreement with the Surrey County Council, modelled somewhat similarly on the arrangement we have with Greater Manchester. So we are committed to local leadership, but as Jim Mackey said yesterday, not simply a return to each organisation or institution doing its own thing, but local leadership as systems with accountability for population improvement, but without all of the fragmentation and the gubbins that people are sometimes currently required to work under. So I don't think, as we take stock on where we've got to, we should have anything other than pride in the work of the National Health Service over the last year. I don't think we should have anything other than quiet confidence that we know what we're doing for the year ahead. But having said all that, I also know that we should acknowledge just how difficult it is, and it is going to be. And this requires continued acts of unparalleled leadership, actually. People here and across the NHS, we're at a time of leadership renewal and change. For many leaders of individual organisations, they're being asked to take on wider responsibilities as well. For many frontline leaders, we're asking them to help play national roles alongside that. We're in a period of leadership transition with NHSI, and I'm looking forward, thanks to the brilliant work that Jim and colleagues have done, to working with new leadership there to get the right join-up between NHS England and NHSI going forward. But all of this, of course, is a means to an end, and I just end by sort of reflecting on some of the people that I've actually spent time with over the course of the last several months. I think about the school friend of mine who I'd not had any contact with for, I guess, 30 years, and she got in touch with me just after Christmas to say that her daughter, a student at university, had just unfortunately committed suicide, and she wanted to come and talk to me about child and adolescent mental health services. That makes it very real. I think about the colleague, the friend, at work, whose husband recently found out he had late-stage lung cancer, and the discussion they needed to have with their young children. And that, of course, makes very real the discussion about cancer services improvement and early diagnosis. I thought about visiting my cousin in a hospital in Birmingham who'd been medevaced, having become seriously ill on holiday, to intensive care at a hospital that actually had been under considerable difficulty and some bad CQC ratings, and talking to the nurses and the intensive care consultants there, the brilliant, brilliant care that she received. Talking to the angry mum who came to see me about the fact that her daughter was still, in effect, incarcerated in an outmoded learning disability institution. And our change program to re-provide humane community services not yet had an impact on her life. And I remember the conversation with the psychiatrist in the substance misuse and drug clinic in Chelmsley Wood housing estate just near where I was born in Shard End, talking about the impact that lack of services were having on substance misuse and the lives of some of the poorest people in our country. And so we can have the conversations in the abstract about urgent emergency care and intensive care and mental health services for children or young people and cancer and learning disabilities and prevention, but it's those stories that, those are the conversations I have, you have the same conversations. And it's that reminds us that, yes, we have a plan. We know what we're doing. It's complex and it's challenging, but frankly, let's stay focused, let's stay practical, let's stay positive, and let's get on with it. Thank you.
Thank you very much indeed, Simon. We've only got a limited amount of time. I'm going to ask you one question. I'm going to take, I think, 4 questions from the audience. But we asked our members what subjects they wanted to talk about, and you won't be surprised that the first one was around funding. And you've raised...
I point out the Secretary of State is leaving at this point.
I tried this on him earlier.
Don't worry, Jeremy, we're good.
You have expressed some concerns in the past. So how, as you look over the next period, how concerned are you that the cumulative effect of austerity means that even well-run organizations or those whose configuration in the past has not been terrible could be facing really quite difficult situations, in spite of, you know, the good things that are happening in the vanguards, which should, in a way, be helping them to save money?
Well, I think that's absolutely the kind of lived experience of lots of people across the health service. I mean, I think kind of 3 things are true. First, that we have an incredibly efficient health service in this country, more so than just about any other industrialized country. Secondly, over time, and this is not a new statement, but over time, of course, if the country wants to continue to have a brilliant health service, it's going to have to resource it, and that's always been true for the 69 years of our existence. But thirdly, the third truth is that there is, despite all that, still actually waste and inefficiency amongst our services. And the issue is that some of that inefficiency and waste is kind of getting harder to get at because it's kind of more profound. It's actually about the sort of handoffs between different parts of the organization. It's about action that requires different entities in an area to act together rather than individually. If you look at the back of the Next Steps document, the sort of 10-point efficiency plan for this year and for next year, actually there's some practical stuff that kind of maybe we should have done it 5 or 10 years ago. We haven't. We've got to work our way through that, not least because until we've got that, it's going to be hard to win a further argument with the public.
And how much progress on, from your seat, local relationships are absolutely central for how you drive this stuff forward. How does it, what does the map look like in your head? Or is it a normal curve? You've got some guys who are doing it great there, in the middle's slow, and there's some terrible ones.
I actually think that sort of culturally, this conversation has moved an awful long way, even in 18 months. And I think where we're at now is that, for the most part, the spirit is willing, and now we've just got to ensure the flesh is strong. There are a few places where there are those kind of, there's that standoffishness. But I think we kind of have a sense of where they are. This kind of difficult process around the sort of local capped expenditure process is kind of, drawing some of that out. I think we get the fact that there are some really difficult decisions to be made if we're going to kind of make the money work during 17-18. And I and colleagues have got to engage directly with that, with individual systems and leaders.
Okay, I'm going to take, as I say, let's say 3 questions, and if you could make the question quite short, and I'll encourage Simon to make the answer brief as well. Okay, so any paddles in the air? Just trying to... Sorry.
You got
number 3, thanks.
Hi, Jessica Sokolov, Shropshire CCG. I'm sure you'll be delighted to know that I've read Next Steps and most of it makes sense to me. But the bit that I could do with some greater clarification on is the actual usefulness of the extended access primary care agenda, because it feels intuitively that what you're doing is you're asking a stressed and under-resourced workforce to do more, and that doesn't feel like a positive way to tackle a workforce issue. And it also feels that by increasing access, what we are doing is we're encouraging people to come more. We're building in additional demand. And I'm wondering how that's been factored in and how we can evidence the usefulness of expecting people to do this additional work.
Well, I think there's a legitimate point there around the pressures on the workforce as exist. And this won't work unless it's also accompanied by some fairly substantial changes to primary care provision. And when we talk about hub working or federations or super partnerships or any of the other changes that are really beginning to break out in many parts of the country now, that's kind of what it's going to take. That's what it took in Frimley to produce those changes in Andrew Morris's area. And that's what's happening in many other parts. It may be harder, perhaps, in Shropshire or some of the areas where you've got more practice dispersion, but team working is not, in that sense, just about being in a big building. It's not about the buildings, per se. But I think, if I can just push back, though, on your point that as we make general practice more accessible, more people turn up. I mean, the corollary of that is we should sort of shop other than for an hour or 2 a day, and then our sort of demand management processes would be kind of... I think the problem with that is that actually the reason we have a well-functioning NHS is because of the accessibility of general practice. That doesn't mean that GPs can't make smart decisions about offers of support from other team members, other ways of interacting with the practice, but we do actually want accessible general practice, and the accessibility of general practice has been getting worse. I accept that that's partly because of the staffing issues that I've described, and that's why the staffing issues, the funding, the redesign of primary care itself, and the availability of services for patients, those 4 things have got to go hand in hand.
Number 2.
Wayne Farran, Newham Clinical Commissioning Group. Really inspired by your comments about the accountable care systems, but wonder about the absence of any reference to STPs in your speech. From my perspective, there seems to be a tension in terms of progressing those 2 issues. I just wonder if you say something about that. And also, I've asked you in the last 2 years about your ongoing commitment to delivering on race equality, and so pleased to see the flags. Can you just give us a little update on what you've actually done over the last 12 months in addressing last year's question about changing the nature of your own organisation?
Sure. Briefly. Okay, so on your second point there, as you know, the NHS Quality and Diversity Council that I have the privilege of co-chairing has now for the 2nd year published the RES data across the NHS. What that shows is some small movement, but nevertheless some early signs of progress on both what the experience of being a BME member of staff versus a white member of staff is like across the organisation, and in some boards, increased representation of BME governors or non-executives and, in some cases, directors. But clearly, we're nowhere near kind of mission accomplished on that. Inside NHS England itself, I mean, one of the things I'm proud of is that over the last 3 years, our employee engagement scores have gone up by 10 percentage points, despite lots of change. but we've still ourselves got work to do on this, and at our all-employee discussion call on Tuesday, I was rightly challenged by a young black member of staff who wanted to know whether we're going quickly enough inside NHS England ourselves on these points. So I think the agenda is very much alive, and I think you're right to ensure that all of us are sensitised as we think about the work we do over the next year. On STPs, no, I mean STPs, look, what are STPs? We talked about them as sort of proposals and plans and partnerships. The fact is they are a space, a mechanism, a vehicle for ensuring that we have conversations between NHS organisations, local government, and indeed the voluntary and third sectors around how health and care needs to improve in a given geography. And I think we're going to see some sort of evolution in the shape of some of those. We are going to see some leaders stepping in to lead the STPs full-time over the course of the next several months. And you're going to see that when we allocate 325 million of capital next month, alongside the annual CCG scoring, the assessment framework will do the same for STPs, and increasingly that will be used as a vehicle for making these kinds of changes and investment decisions. So, you know, I think in some parts of the country people may just choose to call them something different, given the acronym has kind of spiraled in a particular direction. But the purpose that we've got to be more than the sum of other parts, that clearly is more relevant now than ever.
Last question, number one.
Tara Donnelly, Chief Executive of the Health Innovation Network. Excuse me. Hearing you, Simon, and indeed reading the refresh, makes me think that AHSNs are an idea whose moment has come. But I wondered what you thought, and whether there are particular areas that you would be keen that me and my 14 colleagues covering England focus on more going forward.
Thank you. Yes, that's what is called a leading question. But I do think AHSN's actually time has come. And in fact, one of the things we're doing today is launching the second round of bidding processes for the innovation and technology payment tariff, which we did last year at Expo. And AHSNs have been very important in helping drive some of that innovation. But I think there are some other pieces to this as well. As a country, obviously, as we go into Brexit, there's a sort of big debate about how we try and ensure that the sort of economic growth engines in this economy continue to do well. One of them is the life sciences industry, and there's potentially a kind of win-win between the work of the NHS, the work of the life sciences industry. I think AHSNs can be the kind of vector for those more sort of elaborate partnerships, frankly, that we're going to need. We've got some sort of pretty clear ideas that will probably be launched as part of what the government does later this year. The truth is that different HSNs have kind of set different agendas, and I think we're trying to kind of get a more sort of shared view on what the HSN impact should be, whether it's stimulating early stage kind of innovation, or whether it's actually about adoption and diffusion. There's a whole agenda around medicines optimization, for example, that some HSNs have been really driving. So in a nutshell, it's probably too long a conversation to go into now, but yes, I think HSNs have got to kind of step up as you are, and there's a whole field of impact that we need you to have.
Okay. Can I ask you to thank Simon very much indeed? Simon,
Sure.
thank you. Okay, thanks. Right, get shot by the exhibitors again.
What's that?
Shot by the exhibitors again.